Minuscule, messy, and Malefice.
Good morning, and I'm going to present on behalf of Medicine 3 on the topic all that are minuscule, messy, and malefics. There is 25-year-old Mrs. V who presented to us at 14 weeks of gestation. She was actually referred to us in view of an incidental mass which was found in the anterior mediastinum, which was detected during her usual antenatal USG. She did not have any symptoms or any signs. So because she's an antenatal lady, we proceeded with an MRA of the thorax, which showed the following findings. There is a cystic lesion in the right lower zone of the lungs. So these are the images. So what are the probable differentials? I would now request the audience to log into Slido and pop in your differentials. Yeah. The code is 4159705. The ones which are here are thymoma, choristoma, metastasis, hydatid cyst, lymphoma, and again hydatid cyst. What we considered was the anterior mediastinal mass, lymphoma followed by thymoma, teratoma, lung abscess, hydatid, and fork on the lower side. Coming back to her, she was a 25-year-old at 14 weeks of gestation who was referred to us. When we went back and asked about her symptoms, there was no history of any cough, chest pain, dyspnea, hemoptysis, or trichoptysis. There's no history of any weight loss. There's no history of any paraneoplastic complaints. There's no history of any hoarseness of voice. Otherwise, she's a gestational hypertensive and a hypothyroid who's on her regular medications. There's no family history of any malignancies. So coming back to her examination, she was otherwise a comfortably going lady with no pallor. Her vitals were stable. Respiratory system examination wise, there were no significant findings, and CVS and abdo and all were normal. So investigations wise, we proceeded with USG abdomen, which showed a well-defined heteroechoic lesion superior to the liver, which was within the thoracic cavity, and it was in the size of 8.3 into 9.2 centimeters. So since she's an antenatal and being cautious of the radiation exposure, we went ahead with MRI, which showed a well-defined cystic lesion in the right lower hemithorax, which was in the size of around 10.1 centimeter in the greatest diameter, causing a mild indentation of the right atrium and mild inversion of the hemidiaphragm. And there was minimal right pleural effusion. And her alpha fetoprotein levels were also estimated, which was around 25. The rest of the investigations are unremarkable. So our diagnosis at this point is a mature cystic teratoma of the right hemithorax. So I'll now like to talk on the evaluation of mediastinal masses in pregnancy. So while looking at the incidence of the anterior mediastinal masses, the thymic lesions form a major core, like thymic malignancy and the benign thymic lesions contribute to around 40%. This is followed by lymphoma, which occurs in around 25%, followed by thyroid and other endocrine tumors, followed by benign teratoma, which is 10%, and malignant germ cell tumors, which are around 10%. So in the reproductive age group, which is between 20 to 39, the majority of the anterior mediastinal masses are the lymphomas, followed by thymomas and teratoma. So most of these, coming on to clinical presentation, most of these are detected incidentally. However, 60% of the patients are symptomatic. While talking of the symptoms, the predominant symptom at presentation is cough, but if the lesions are invasive or if there's a malignant lesion, they may present with the compressive symptoms like chest pain, dyspnea, voice hoarseness, hemoptysis, and dysphagia. They can also present with superior vena cava syndrome if they are infiltrative. So the major differentials for an anterior mediastinal mass based on the incidence being lymphoma, thymoma, and teratoma. How do we differentiate these three based on the clinical findings? So for any lymphoma, the symptomatology, you will always have B symptoms which are present, like fever, night sweats, and weight loss. And the clinical findings wise, there are always lymph nodes which are enlarged in the cervical, supraclavicular, and axillary regions, which are like more pointing towards lymphoma. Whereas in thymomas, mostly it presents with paraneoplastic syndrome like myasthenia gravis. And there will be also a history of recurrent infections due to hypogammaglobulinemia and pure red cell aplasia also. And it's also associated with autoimmune disorders like SLE polymyositis. Whereas teratoma is mostly asymptomatic. And when they are symptomatic, the predominant symptoms being cough, chest pain, dyspnea, pleural effusion, and superior vena cava syndrome. So when these lesions are present, what is the indication of biopsy? So mostly all of these lesions or biopsy is not indicated unless and otherwise it's a lymphoma. For a lymphoma, the histology is necessary for the diagnosis and planning of treatment. So based on the clinical syndrome and the suspicion of the lesion, the further management is proceeded. So for any anterior mediastinal cystic lesions which is detected, if it is a probable cyst, there is no follow-up which is recommended. But when it is an indeterminate lesion, so the further follow-up and management depends on the size. So for a lesion which is more than 10 centimeter, it's recommended to follow up with the CT or an MRI at 3 months. So when there is a stable lesion or if there is decrease in size, the lesion is kept on for follow-up after 6 months and then after 12 months and then after 24 months. But if there is a newly appearing solid component or if there is an aggravation of the wall thickening, surgical resection is recommended. So the same with the lesion which is less than 10 millimeters. So for a lesion which is less than 10 millimeters, the follow-up is at 6, 12, and 24 months. So if there is an increased or a newly appeared solid component or an aggravation of wall thickening, a surgical resection is recommended. So what are the complications which we expect? Like the lesions can rupture into the pleural space or the pericardium and can acute mediastinitis. For this patient, especially in pregnancy, this management of during delivery, the management of her airways become difficult because of the presence of an anterior mediastinal mass. So so coming back to our patient, she presented to us at 14 weeks. So she was kept at MDT for discussion regarding the conservative versus the surgical management. So surgical management for this patient is best done at the second trimester. So she was given the option of both conservative versus surgical. And she's yet to decide. So if there is surgical management, it is planned at the second trimester. And otherwise, if she opts for conservative management, to reassess the tumor size at 24 weeks and then proceed. So learning points: anterior medial sternal masses and the clinical presentation, and large teratomas can still be asymptomatic.
Thank you.
How was the diagnosis confirmed?
Sir, the clinical, the MRI findings, sir,
The MRI findings.
so if there is a fat standing, and if there is a definite margins more suggestive of a teratoma, sir, definite fat strand,
Suggestive or confirmation?
suggestive of a teratoma.
So then how do you decide this teratoma? Only suggestive. Why did she have a right node location? So looking at an image and making a diagnosis of radiology is very troublesome. There are very few conditions where the radiological appearance is absolutely diagnostic of the condition. Okay. You can describe the lesion and provide a list of differences. Confirmation based on some other things. Did you, in your reading or discussion with the radiologist, are they able to confirm that this is a teratoma?
So this image radiologist, and a cystic lesion is unlikely to be a lymphoma or a thymoma. So here the differential was more towards mature cystic teratoma. The caveat here is normally we use beta HCG to diagnose teratoma, but in pregnancy the usefulness of that comes up. The major issue here would be differentiation between a mature cystic teratoma versus the immature teratoma. The immature teratoma requires urgent intervention followed by chemotherapy. But the imaging it was a well-defined, encapsulated lesion without any invasion. So diagnosis was more towards mature cystic teratoma. So this was also discussed with the patient regarding do we need to we can't do a biopsy here. It has to be entire excision of the lesion and the central focus. That was discussed with the patient, and finally, patient actually opted for surgery. Patient is planned for the surgery.
The reason second trimester for PPP safety?
So second trimester, third trimester, the uterus becomes too big and the risk of surgery is quite high. First trimester, there's a loss in first trimester. So second, any surgical procedure, second trimester.
Sure, the next person is Dr. Bobby